Good morning once again. I want to ask us to please turn our cell phones to silent and make sure they're off the table so we can avoid unnecessary feedback noise. Pardon me. You may notice board members accessing their laptops during the meeting. They are using their laptops solely to access board information and materials in electronic format. This is an official meeting of the Medical Board of California, and as such, disruptions of the board's business will not be tolerated. We have designated time on the agenda for public comment and ask for public comment on each agenda item. I ask that you be respectful of the need to conduct the board's business. Should anyone disrupt the board meeting, I will ask that person to conduct himself or herself in a manner that permits the board to transact its business. This meeting will be available via teleconference. Individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconferencing process. For those members of the public participating via teleconference, please wait until the moderator has introduced you before you make comments. Please ensure that if you are watching the board's webcast, that you turn down your speakers when you address the board via teleconference. To request to make a comment during the public comment period, press *1. You will hear a tone indicating you are in the queue for comment. If you change your mind and do not want to make a comment, press the #sign. Assistance is available throughout the teleconferencing meeting. To request a specialist, press *0. Each person will be limited to 3 minutes per agenda item. However, during agenda item 11, public comments on items not on the agenda, the board has limited public comment period for individuals on teleconference to 20 minutes. In addition, public comment for individuals here at the meeting will also be limited to 20 minutes. Therefore, after 20 minutes, no further comments will be accepted. During public comment on any other agenda item, 10 minutes will be allowed for comments from individuals on the teleconference line and those in the audience. After 10 minutes, no further comments will be accepted. Si Vang, hello, will be assisting me with receiving public comments via teleconference during this meeting. The board welcomes public comment on any item on the agenda, and it is the board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item, and you wish to speak on that item, please raise your hand and you will be recognized. I would like to remind all speakers to complete a speaker's slip so that I can call you by name at the appropriate time and that the record of the meeting is complete. Please give the speaker's slips to Ms. Lisa Toof. Ms. Toof, good morning.
Good morning.
I will do my best to call upon everyone who has supplied a slip for the agenda item and to recognize those who wish to make any last-minute comments. But we ask you to fill out a speaker slip after your comments so we have it for our record. I want to remind all speakers to please stay on topic and keep your comments to 3 minutes or less. We may take some items out of order to accommodate today's schedule. Before we get to our business, I would like to recognize Jason Weiss. He is a member of the speaker's staff and is here this morning. Hello. Thank you for joining us today, and please send our best to the speaker. I would like to call this meeting to order and ask that Ms. Toof please call the roll.
Dr. Gananadev?
Here.
Ms. Pines? Dr. Bishop?
Here.
Dr. Kraus?
Present.
Dr. Levine?
Here.
Dr. Lewis?
Present.
Mr. Louie?
Here.
Ms. Shipsky? Ms. Wright?
Here.
Ms. Yaroslavsky?
Present.
Dr. Yip? Mr. Serrano-Sewell?
Present.
Thank you. We have a quorum.
Thank you. Moving on to agenda item 14, public comments on items not on the agenda. Please. Genevieve.
Good morning.
Geneviève Claverol. You know, yesterday about the issue of Ebola, and I don't know if you are aware, but this morning there is a congressional hearing on Ebola, who has been called by Darrell Issa. I know your next meeting is not until a few months from now, but maybe it will be important to put it on the agenda for next time to see what's been done in California and so on.
Thank you for your comments. The next speaker slip is Clarine Zettel. Charlene, good morning.
Good morning. It's great to see everybody. Thank you.
Good to see you again.
Hi, Charlene Zettel, Donate Life California. First of all, I want to thank all of you again for your public service. I can only imagine the hundreds of hours that you give of your time to protect the people of California and to protect the medical professions. I want to thank you especially for being our unofficial sponsor for the Donate Life plate. Since I was last here, we have been working to sell the plate, but we fell short of our goal for a number of reasons. First of all, we changed the plate from a pink dot plate to our Donate Life logo, which is the national Donate Life logo. There was a change of heart at the DMV, and we were allowed to use our registered trademark. So we are now working hard to sell the required 7,500 paid reservations before the DMV will produce these plates and manufacture them. And I also want to take one moment before I leave to ask, to present this to your board president. A couple months ago, I went and visited Ms. Kirkmeyer, and we had a photo here of a mock personalized plate, and this one says MBC for you, and we have Ms. Kirkmeyer holding it, and I wanted to present it to her. And I would encourage all of you to go to donatelifeplate.org and reserve your plate. Together we can save more lives. Today there are 22,000 Californians on the national transplant waiting list, almost 124,000 nationally. Working together we can save more lives. Thank you so very much.
Thank you for that. Thank you.
Thank you very much.
Anytime. Mr. Vang, are there any comments on the phone?
I have no questions at this time.
One moment. Oh, for later. We'll now move on to agenda item 15, update from the Department of Consumer Affairs. Ms. Lally?
Good morning, President and members. I'm Christine Lally, Deputy Director for Board and Bureau Relations at the Department of Consumer Affairs. Thank you for the opportunity to join you this morning. Director Awit Kadani, Chief Deputy Director Tracy Ryan, and Deputy Director of the Division of Investigations, Mike Gomez, and I continue to have biweekly meetings with your Executive Director, Ms. Kirkmeyer. These meetings are very helpful in keeping us apprised of the issues facing the board and also where the department can be of assistance. Today, I wanted to specifically provide you an update with regards to the proposed Enforcement Program Manager position, a position that I know you are anxious to establish and fill. The proposed position would be responsible for the planning, organizing, and directing of the board's overall enforcement program, which includes the probation, central complaint, complaint investigation, and discipline coordination units, as well as providing settlement authority to the Office of the Attorney General on disciplinary decisions. In May, board staff submitted a proposal to establish the enforcement program manager, which is a career executive assignment, also known as a CEA, and the specific level is a level A. In June, the department's Office of Human Resources approved the request and submitted it to the Department of Human Resources, also known as CalHR. In September and early last week, CalHR requested additional information, which the Department of Consumer Affairs gladly provided. And I'm here today to share some very good news, which I know Ms. Kirkmeyer will be ecstatic to receive, is CalHR has approved the enforcement manager position. They notified us late yesterday. So the next step in the process will be for it to go before the vote of the full board of the State Personnel Board. So as soon as they have that calendar, they will let us know, and we're hoping it will be within the next month or two. So very, again, happy that this position, it's taken a while. It's been about 6-7 months, I think. So it's been a while coming, but very happy to share that with you today. So that concludes my update. If there's any questions from the boards or anything that I can help you with.
Thank you for that update and report. Are there any questions or comments from the members? Ms. Yaroslawski?
Good morning. I want to thank you for that
Good morning.
report as well. I would just like to ask you, and your frame of reference, what is the timeline we're looking at between now and the person being in place?
Well, again, the next step is for it to go to be scheduled for the State Personnel Board. So we're hoping that will get on their calendar within the next month or two. Then I would allow, another 30 days once it's actually posted. Then you have to do interviews. So I would, at an aggressive timeline, I would say 4 months.
Thank you.
Doctor?
Thank you, Ms. Lally. Thanks for coming. And
Of course, my pleasure.
for me, it mind boggles me how long it takes to get these positions approved, which, I mean, we have no deputy director, we have no chief there enforcement. It just takes, it puts so much on our executive director. So that's why I'm just trying to see how you can expedite. And my next one is, when do you think Breeze and the AG's office, whatever system they have, can talk to each other and we can really get things done? Do you have any timeline by any chance?
I don't have a timeline specifically on that interface, but I was notified that there were some questions yesterday on the Breeze project, and I think there was some specific questions regarding the enforcement reports and when that will be fixed. I know that there is I would say, phase 1 fix that is going in on November 7th. And then, as your executive director is involved in, we're holding enforcement user group meetings where all of the different boards under DCA, their enforcement staff are providing information so we can standardize the enforcement reports. And then once that is, we come to consensus on that, then that final fix will go into the system. But we're expecting semi-fixes on the November 7th drop, which is commonly referred to as 1.2, but that's getting into the details.
Are there additional questions or comments from any members? Seeing none, thank you once again.
Thank you.
It's always good to see you.
Appreciate it. Likewise.
Are there any comments from the phone? I didn't ask for public comment. I will. Thank you. And seeing no public comment from the audience, I'll now move to agenda item 16, update and consideration of recommendations from the prescribing task force. Dr. Bishop and Ms. Yaroslawski.
Thank you, Mr. Serrano-Sewell. I would like to begin by taking the opportunity to thank Laura Sweet and Letitia Robinson for their outstanding work in the board's version of the guidelines. In addition, I want to thank every licensee organization, public entity, and other state agency, and everyone else who weighed in on these guidelines and provided the much-needed input to this final product. The board received numerous comments on this document, and I think the document you have in your packets shows the hard work that was put into this document. Everyone's time is precious, and we appreciate everyone who gave of their time to assist. On November 29th, 2014, the Prescribing Task Force held a meeting to finalize the revisions to the board's guidelines for prescribing controlled substances for pain. Prior to the meeting, the board staff had incorporated a significant amount of information from those entities I previously mentioned. In addition, board staff met with an expert in pain management and an expert in emergency medicine. Board staff has not only posted information about the meetings on its website, but sent out over 100 emails to those who have requested updates, shown interest in this topic, or who the board thought should be part of the process. As previously stated, information has been gathered from several other current and existing guidelines and incorporated into the board's revisions. Again, the September meeting had representatives from the prescribing and dispensing communities, law enforcement, and other regulatory boards. I would like to draw your attention to pages BRD 16-1 through 1685.
Thank you, Barbara. I'd like to make clear that this document is just as it is entitled. It contains a compendium of guidelines. These guidelines are intended to provide physicians with a framework to assist them as they prescribe controlled substances for pain. The document provides useful tools and links that can be used for this purpose. These guidelines are not regulations. The board will not be going through the rulemaking process to adopt them as regulations. The document is also not intended to delineate the standard of care, and simple deviation from these guidelines alone will not be used as a cause for discipline. The board has several documents on its website that are used to assist physicians and/or other allied health providers. These include a statement on recommending marijuana that provides guidance as well as information for terminating a patient relationship. The board also has guidelines for licensed midwives on the website. All of these documents were created to assist the individual. They are not enforceable regulations, but they are useful to the providers. If any physician is brought to the board's attention, the board will submit the matter to an expert reviewer, and that expert will opine on whether the actions of the physician deviated from the standard of care in the community. I think this document will provide much-needed guidance for physicians. I would now like to turn it over to Laura Sweet, who will briefly walk us through the document, and then Ms. Sweet, Ms. Yaroslavsky, and myself will answer any questions that the members may have. Ms. Sweet.
Thank you, Dr. Bishop. Before I begin, I wanted to make certain that everybody has the additional 3 pages and has been able to substitute them for the ones that are in the original packet. Wonderful. This document continues to be improved up to the minute. I would also like to start off by expressing our gratitude to all of the people who graciously offered their expertise and time in creating these guidelines for prescribing controlled substances for pain. The feedback we received was instrumental in making this product as comprehensive as it is. It was clear that the wide variety of people who participated in this process, despite coming with diverse specialties, backgrounds, and interests, wholeheartedly shared the common goal of providing high-quality medical care and improving patient safety. Before discussing the content of the guidelines, I wanted to take a moment to explain the methodology we used. First of all, we prepared a very large matrix that compared and contrasted numerous prescribing guidelines for pain management. And from that matrix, we were able to make certain that in our guidelines, we included topics where consensus existed among other medical boards, government agencies, and the Federation of State Medical Boards. That was predominantly what the first draft consisted of. The later iterations were based upon the substantial feedback we received, which came in the form of letters, emails, phone conversations, the provision of relevant medical literature, meetings with experts, and comments from public meetings. We spent a considerable amount of time creating a preamble that fully sets forth the intent of the guidelines, the primary objective being improved patient outcomes and the reduction of prescription overdose deaths. We underscore the complexity of treating a patient with long-term opioid therapy for chronic non-cancer pain. We wish to make it clear that the guidelines do not mandate the standard of care. We also want to assuage physicians who are concerned that deviations from these guidelines might be cause for discipline, that we recognize that deviations from the guidelines will occur and may be appropriate depending upon the unique needs of individual patients. We want to leave the reader of the preamble with the adage that medicine is practiced one patient at a time. The next section, Understanding Pain, is included as excellent educational information. The California Medical Association was very generous in sharing several portions of its document on prescribing opioids, and this was a topic we felt was important to include. Here, in this section, pain, subtypes of pain, and commonly referenced terminology such as addiction, tolerance, etc., are defined. The next section is devoted to special patient populations. For example, patients suffering from acute pain, patients seen in the emergency department, pediatric patients, pregnant patients, patients with a history of substance abuse, psychiatric patients, etc. And here we offer treatment considerations for differing patient populations or scenarios. The next section is entitled Patient Evaluation and Risk Stratification. Every set of guidelines we reviewed and our experts agree that risk stratification is critical when initiating treatment for long-term opioid therapy for chronic non-cancer pain. We also provide links to useful tools for the physician to utilize in conducting a thorough evaluation as well as assessing risk. The next section addresses consultation, and in another example of the value of the feedback we received and incorporated, one of our partners made the excellent suggestion of moving this towards the beginning of the patient relationship to highlight the benefit of consultation before issues develop. We then move on to the sections of treatment plan and objectives, patient consent, and the pain management agreement. We recommend the physician and patient develop treatment goals together. We list items typically contained in inpatient consent, and we recommend the use of a pain management agreement and provide samples of such. We felt it was important to include the next section, counseling patients on the risk of overdose and response, to further support one of the objectives we cited in the preamble, and that is the prevention of overdose deaths. Initiating an opioid trial, the next segment, is important because we hope to highlight the recommendation that all patients who initially receive opioids for chronic non-acute and non-cancer pain do so on a trial basis with specific evaluation points in order to determine if opioids should be continued past a certain point in time. Continuation of opioid therapy after an appropriate trial should be based on outcomes such as the patient making progress towards specific functional goals and improvement in pain status, the lack of evidence of medication misuse, abuse, or diversion, etc. Ongoing patient assessment emphasizes the importance of continuous monitoring after the opioid trial is considered successful and how this should continue for the duration of the treatment. Again, we link to tools to assist the physician in measuring the efficacy of the opioid therapy. The next section, compliance monitoring, provides guidance on how physicians can determine whether provisions of a pain management agreement are being heeded. For example, the use of the cures report, drug testing, and pill counting. We also include information and suggestions for physicians whose patients are not compliant with the pain agreement. Next, discontinuing opioid therapy addresses the circumstances that might require a physician to change the course of treatment. We attach strategies for tapering and weaning patients from opioids. The next section addresses medical records, and that's pretty self-explanatory. The final two sections, supervising allied health professionals and compliance with controlled substances laws, suggest physicians who supervise other healing arts professionals be aware of the laws governing them and those whom they supervise. As for the compliance with controlled substances laws section, we just link to the actual laws. We believe we packed a substantial amount of information in the 24 pages of text and then supplemented that with as many resources as practicable via the appendices or links to websites that will hopefully further assist the physician by putting this information at their fingertips, so to speak. I want to conclude this report by once again expressing our gratitude for all of the assistance we received, even down to grammatical reminders. We believe this truly collaborative effort will make tremendous strides in protecting medical consumers in the state of California. That concludes my report.
Ms. Sweet, thank you for that report. Are there any questions or comments from the board? Go ahead.
I just want to take this opportunity to say how grateful I am to have worked with Laura Sweet and her staff and Kim Kirchmeier on this document. The amount of work they put in is amazing, and the document is truly a testament to their skill and hard work. Thank you very much.
Thank you. Ms. Yaroslavsky?
I would echo Dr. Bishop's remarks. This has been a long time coming, and the evidence of the collaborative energy and efforts, in addition to doing their regular jobs, staff was just totally pulled it all together and made it happen. And I want to thank them publicly, as well as suggest that since this document, in my opinion, is an excellent document, that we take an opportunity to take a look at those that did participate, make sure that we try and either email a link to the document or send them a document, but also taking a look to how to further do it. But I want to thank the staff tremendously. Thank you.
Thank you. Dr. Lewis?
Oh, hi. Yes, I can echo 100 times what my other colleagues have mentioned. This is quite, it's like the New and the Old Testament combined. So it's really not quite a religious experience, but I'm sure approaches one.
Especially in a time of separation of church and state. You know.
Separation of church and state, yes, here. I have some questions about the intended audience for this, because it is such a massive, complete document. And I'm wondering how you roll it out to the general practitioner who does treat a majority of patients with chronic and acute pain. And when I look at this, and I've looked at the document, there's so much in there. I wonder how you introduce it to some of us, simple docs who need to know and quickly find what we need for that particular patient that's sitting in front of us. So that's my one question. It's the rollout, because, I'm going to look at this and say, oh my, it's so massive. So that's the one question. And then we also have to remember there are realistic expectations of our patients, and we have to remind them that we can't treat 100% of your pain. And you and I have talked about 30% is a probably reasonable goal of improvement of chronic pain. I mean, 30% to us sounds like a small amount, but if you can get 30%, you're pretty successful. And so do we have any tools for patients to take and say, let me read, let me think of what I can do myself to participate in this?
Excellent questions. A couple of things. When these are rolled out, we'll certainly be writing an article in the newsletter to advise physicians of its existence. And also, the medical board, we are working with the California Department of Public Health on a campaign, informational campaign in order, and these guidelines are kind of instrumental as a jumping off point to let people know through articles, through social media about the existence of these guidelines. And you raised a really good point, because we realize that patients will also read this, and this will be informative information for patients, so their expectations are also reasonable. And through those different types of social media avenues, we're hoping to reach patients in that way. And I believe Ms. Kirkmeyer has some additional comments.
Thank you.
So just following up on the outreach on this, I've spoken a little bit about the work group that I've been involved in with the California. It's really being headed up by the California Department of Public Health. We are working on a statewide initiative on this issue of the epidemic of drug misuse and abuse. And they have been waiting for these guidelines to actually launch a whole outreach program. They actually have a press release that will be released as soon as ours goes forward. So we're the driving tool for this issue. And then they will see where each other entity that's involved in this, where they fit into the outreach to everyone, not just physicians, because through even this work group, we're going to be able to hit Medi-Cal physicians, because we have the Department of Healthcare Services in there. We have a lot of other entities. We have the Department of Education, who they're going to start working on things that are going out to students and to parents. And then also just the Department of Public Health in reaching out to the public on this issue and how important it is. We also have the pharmacy board who's involved, who will be getting out information about to the pharmacists, not only to pharmacists, but how important it is to maintain and be aware of your controlled substances that you have in your home. So this really is the first step to a huge outreach outreach within the state on the issue. For us, the other thing I wanted to let you know is that we're actually planning, hopefully, I'm not sure how all of this works because IT is not my forte, but what we want to do is be able to work this into an application that will be able to be put on your smartphone to where you have these guidelines right at your fingertips and will be able to then access the information right there. And then as far as continuing outreach to public, our task force is not done. This is just one step of what they're going to be doing, and the next step they're going to be looking at is best practices. We have the intent of putting together a web page that's not only available for physicians and for tools for them, adding on to these guidelines, and I think Ms. Sweet can add even a little bit more onto that we're going to be doing, but then also putting out best practices for the public as well. So we're not done. We have a lot more work to do. This really is truly the starting point.
Yeah, Doctor?
Thank you. Ms. Sweet and Dr. Bishop and Ms. Jaslowski, wonderful job. Couple of suggestions for distributing it. I think you one of them is work with the agencies which give the continuous medical education credits. They can take our document and create, in the end, an exam, and then they provide the CME credits. Till now, that CME credit thing has been hijacked by the pharmaceutical industry. You're just pushing their drugs rather than CME providers who are doing. I think if you work with, for maintenance of certification, some of these things have to be not only read, but also you got to answer the questions in the end and have to get 75% of your things right. So those, for especially like family medicine, family practice, internal medicine, these are the people who get into trouble almost all the time, not the pain management doctors, because they know what it's supposed to be. It's the primary care docs who gets into trouble. So if we can do that, I think that makes it, that becomes part of their recertification process. So that way they can get credit for what is beneficial for them. So if we do some innovative things with these agencies, I think we get a lot more out of it rather than just being on our website and being distributed through the Department of Public Health.
Great, thank you.
Dr. Levine?
Thank you. There are sort of three gaps that exist between what's current practice and what's ideal practice. And I mention this only because I think you've done an admirable job in beginning to think through closing the three gaps. The first is the knowledge gap, and the guidelines, and I think you've boiled the ocean here in a very effective way. The guidelines really provide a wonderful basis for identifying at least what knowledge currently exists. Then there's the knowing gap. Once the knowledge exists, getting it out, disseminating it, ensuring that it's accessible to people at the point where they actually need the information. And the hardest piece, and the biggest gap, if you will, is the knowing-doing gap. So incorporating the information and making it easy to do the right thing at the point of care, that's not something the medical board can do. But by virtue of really effectively doing the first two pieces, and you've laid out a wonderful approach for that, I think it will make it easy for those of us who have responsibility for the knowing-doing gap to actually begin to speed up the pace at which change happens. So again, commendation and great thanks for a wonderful job.
Thank you. Are there any additional comments? Seeing none, may I have a motion to approve the guidelines for prescribing controlled substances for pain?
Move to approve.
There's been a motion and a second. Are there any public comment from those in the audience? I do have a card. Steve? Oh, hello. Good
Good morning, President Sewell, board members. My name is Steve Katolika. I'm the Director of Government Relations for the California Neurology Society, the California Society of Physical Medicine and Rehabilitation, and the California Society of Industrial Medicine and Surgery. The 800-some-odd members of these organizations commend the work of the Prescribing Task Force. We strongly believe that these guidelines will provide clarity necessary to allow physicians to practice medicine one patient at a time without undue fear of doing so. We also commend the living nature of the document as establishing a standard of care, notwithstanding the language, that can be improved on for years to come. Of course, these guidelines are not the only treatment of this issue of prescribing controlled substances. Our constituents with heavy emphasis in treating injured workers face a difficult situation. The Division of Workers' Compensation recently pronounced the board's guidelines as being very consistent with those that the DWC will soon propose as regulation. However, any inconsistency will cause all physicians to perhaps compromise because all of the DWC's treatment guidelines have a long and proven track record of being misapplied by work comp claims payers, primarily to control costs and access and identify physicians they no longer want to treat in their medical provider networks. Ms. Yaroslavsky was recently quoted as stating that the NBC guidelines are not regulations, they're guidelines. She was further quoted as saying that they are another tool meant to help practitioners practice the art of medicine, and we applaud that fact. Unfortunately, the physician community's experience with the application of treatment guidelines in the workers' compensation system is more in line with rigid criteria. Yesterday, I mentioned the harm that's being perpetrated on the citizens of California on a daily basis by the workers' compensation system because UR physicians seem to forget that they are practicing medicine and that they and their UR medical directors are directly responsible for the well-being of injured workers every bit as much as the treating physician. But with this in mind, we urge the board to anticipate that work comp UR physicians will not authorize a controlled substance citing the DWC's guidelines. It's happening now, and there's no reason to think that their motives are going to or actions will change simply because the medical board has issued guidelines covering the same situation. The board can also anticipate that harm will continue to occur to injured workers as a result of these UR denials. Complaints will be submitted, and the board will investigate them in order to establish whether the UR physician's actions were the cause of that harm. The nexus of the issue will be just how similar the division's regulation is to the guidelines established by this medical board. How will the NBC guidelines be applied when establishing responsibility for harm from a UR decision? Where will the authority be found to lie? More importantly, how does the injured worker's health affected? In closing, we urge the medical board to establish these guidelines, but more importantly, that the board uses all of its authority and influence to assure that the phrase very similar or equivalent be eliminated, or very similar, be eliminated from any comparison between the NBC and DWC guidelines in favor of a phrase that has the same meaning as equivalent.
Time is up.
The lives of many sick and injured Californians are at stake. Thank you.
Thank you for your comments. I have another speaker card. Genevieve?
Good morning, Genevieve Claverol. I am one of those injured workers, as well as my daughter, who cannot get our medication because of a lot of those guidelines. And many people in the workman's comp interpret the guideline to follow what they want, not giving the meds to the injured worker. Also, one thing which and first I want to thank Kimberly Kirschmeyer because she has been very wonderful to talk with me when I cannot attend the meeting and share information with me. And you, the board in general, are very kind about that. One thing who have concerned me about the drug issue is that in December of last year, we had a journalist, we decided to do a yellow journalism and put the alarm on opiate usage, really not giving the facts. And actually, California, and to my surprise, California is one of the states who use the least drug, prescription drug. I'm sure none of you probably knew that. But being one of the states with the more conscience about the prescription drug usage, yes, the guidelines are important, but right now we are in an issue where especially pain specialists are scared. They don't want to write prescription for opiate. And recently I went to a neurologist to have a spinal stimulator, put in. He wanted me to sign a document saying that I will not take any opiates for anybody else. Well, I have a pain doctor who have taken care of me for many years. And when I refused to sign that piece of document, he refused to treat me. He said, if you don't, and to me, that's bribing and that intimidation. But I made a verbal contract with my pain physician that I will not take opiates from anybody else. And I have done that for many, many years. And for having a neurologist decide he wanted me to sign that kind of letter and prohibit my treatment if I did not sign it. The only thing I was very lucky, he just came back from Paris and loved French. So I was lucky he decided he will compromise and treat me anyway. But that should not happen. Why this is now such a piece? I understand when people do not obey the law. And I am the first one who is very tough on that for anybody who know me. But I think right now is totally going out of bounds. Like I said, especially when you look at facts, we are the one who use some of the least opiate in the United States.
Your time's up.
Thank you for those comments. I have a speaker's card from Jeremy Adler.
Thank you. I'm Jeremy Adler. I'm a PA. I'm president of the California Academy of Physician Assistants. I also practice pain management and was a co-author on the opiate treatment guidelines from the American Pain Society and American Academy of Pain Medicine, which I see referenced in your guideline. I applaud the Prescribers Task Force for putting together guidelines, especially in a field where the depth of evidence is shallow. It's a challenge, and we faced it in our committee, and I'm certain you did as well. As physician assistants, we're committed certainly to safe prescribing, appropriate prescribing, optimal patient care, and balance that with the illicit use of prescription drugs. We know that we have an epidemic in our communities, and we're committed to doing what we can to minimize that. In 2003, as a part of AB3, CAPA was able to develop an approved course from the PA board called the Controlled Substance Education course. And we use the guidelines that are current with the Medical Board of California to educate now 5,335 PAs on those guidelines, which is over half the PA population in the state of California. So we plan to take the current guidelines that you're working on and include that in our course, and we'll continue to educate PAs on the current latest information surrounding controlled substances. Thank you.
Thank you for your comments. Seeing no additional public comment from those in the audience, Mr. Vang, are there any comments from those on the phone?
We have no questions or comments at this time.
Thank you. There's been a motion and a second. All those in favor?
Aye.
Opposed? Abstention? Motion carries. Thank you. Ms. Sweet, thank you. We will continue to agenda item 17, update on regulatory hearing on citations and fines. Ms. Kirkmeyer.
Okay. First of all, thank you, Board, for approving those guidelines. Under Agenda Item 17, you will see a memo providing an update on the status of these regulations. The members may remember that at the last meeting, it was approved that the board would hold a hearing outside of the board meeting in order to expedite the regulations. A hearing was held, and these regulations will be submitted to the Department of Consumer Affairs next week. These regulations were approved to be effective upon approval by the Office of Administrative Law. So it's our hope that these will be actually effective before the end of the year. And are there any questions? It's really just more of an update. We did hold the hearing, and we are moving forward with these regulations.
Colleagues, any comments or questions? Is there any public comment from those in the audience? Oh, We do. Genevieve? John Viev? Did you care to, you had a speaker's card for 17. Okay, thank you. Are there any comments from the telephone?
No questions or comments at this time.
Thank you for that update. We will continue to agenda item 18, presentation on fictitious name permits. Mr. Warden, good morning.
So today's presentation is just sort of a brief overview of the basics of a fictitious name permit requirements and some basic questions. So the fictitious name permits have been around as a requirement for almost 35 years, so it's not new. And one of the things is some people think that it's new. It's not. It's been around since January of 1980. So one of the things is some people don't know when a fictitious name is required, and it's required for when a licensed physician or podiatrist needs to practice under, or wants to practice under a name other than their name that's their license has been issued to. If a physician has a professional corporation and a name other than their own, or if they have a partnership or a group practice and want to use a name other than the name on the licenses. Some physicians believe that if they have their city-county fictitious business name, that it's the same as meeting the requirements for a fictitious name permit. It is not. So that is an area. It is not the same. Where am I? Then there's a question of why do physicians get in trouble when they don't have an FNP, and it's because one of the reasons is for that specific reason they have their city-county one, so they believe they've covered their bases. If you practice when you are required to have a fictitious name permit and you do not have one, it's considered unprofessional conduct. And does each physician need a fictitious name permit if you're part of a professional corporation or a group or practice? And no, it's one fictitious name permit, and each of the owners of that corporation or practice are listed as part of that fictitious name permit. So there's only one fictitious name permit issued for that name, for that group of physicians. And then the other question is do I have to have a fictitious name permit if I'm just working for another office that it has one? And that answer is no. If you're working for a facility that you're actually allowed to work at, which there are restrictions on who can employ physicians, so those would have to be followed. One of the other things is I'm a licensed physician. Do I need an FNP working for a partnership? That's the same answer is no for that if you're working for them. Here's a couple of examples of when you don't need a fictitious name permit, when you're using your own licensed name, or if you're using your name with Inc. for your professional corporation, you do not need a fictitious name permit. If you want to practice under a different name, for like in this example, the name suggested to be used was Sunrise Medical Group. The doctor would need to have a fictitious name permit for Sunrise Medical Group. So here's one that shows sort of what I made up as the office for the doctor is a doctor practicing under his name under a professional corporation that says he specializes in family medicine, and he does not need a fictitious name permit for that. Here's an example of when you do need a fictitious name permit, and this would be a partnership for the XYZ partnership. They would require a fictitious name permit. Each of those physicians would be listed on that fictitious name permit that are part of that Are there laws and regulations that I should know about? And the answer is yes, there's lots of them. The main ones are the Business and Professions Code, Corporation Code, Insurance Code, Penal Code, Welfare and Institution Code, and the California Code of Regulations. This slide shows the specific commonly used code sections for each of those sections of law, but it's not inclusive. One of the common questions we get is, do I need a lawyer to help me with FMP issues? That's not a question that licensees have to decide for themselves, as the board does not make that decision for you. And what happens if you don't have an FMP when one is required? It's considered unprofessional conduct, amongst other issues that could also be arise due to the violations of possible other code sections. That is only referring to the Business and Profession Code Section 2285. So right there's an old-fashioned insurance claim form, and insurance companies are not required to reimburse you for services rendered if you do not have an FMP when one is required. So that's one of the things. And then here are some of the requirements that are required to have an FMP. So those are all listed there. And with more information on that. So there's quite a bit to do, but not that much. The fee for a fictitious name permit for your initial permit is $50. They have a 2-year renewal cycle. The renewal fee is $40. And then here we have some statistics for the board members who have your packet. You'll notice that there's a new number on that, on the bottom one, for the fictitious name permit renewals. I'm showing 3,833. And in your packet, we actually put in there was 64,714, but that was actually the renewals of the physicians themselves. So we were only off by a mere 60,881 on that. And that concludes the FMP presentation.
Ms. Yaroslavsky?
So I want to thank you for the report. I want to ask if there's a way that, this is like low-hanging fruit. If we could take care of this problem almost with doctors not understanding what the rules are for them, the occasional one we get, it's only occasional, we get an issue. But maybe that as part of the newsletter, some of these questions are very good. The answers are even better. So if we could have maybe every year, every other year, a block of something like this that addresses this, that so the readers of the newsletter would get the information, that this maybe would take care of the cite and fines and the problem.
That's a
On the
great
web,
suggestion.
but it's also as part of the renewal notice, this maybe should also go out, so the doctors that are in business would understand this as well.
Thank you. Dr. Lewis?
Yeah, I wrote down exactly what Ms. Yaroslavsky said, except an additional one other avenue, because we should have 100% compliance. And this is sort of a no-brainer, but we don't. We don't have 100%. So besides the newsletter and the mailing with renewal, you know, these residents will be thinking about getting out of residency and starting their own practices. So it may be another avenue as outreach to remind them about the fictitious name permits.
Yeah, we could actually probably incorporate that in our licensing affairs, because they're starting to get their licenses, even though they're still in residency. That would be a good time to make that.
Right, just to remind them to be thinking about it. Thank you.
Are there additional questions or comments from the board? Looking to my right, I don't see any. To my left? Great. Are there any comments from those in the audience? Seeing none on the phone?
Yvonne.
No questions or comments at this time.
Was that? Oh, hello. Hi. No, that's no problem. Just, good morning.
Good morning, Yvonne Chung with the California Medical Association. One question that we didn't see here that actually comes up, we get questions about this, is what happens when physicians leave a practice or the partnership changes. I think a lot of physicians are unaware that they actually need to change the name. So if you do an FAQ, you may want to add that question as well, that when there's been change in the ownership, I think that's a little less clear, particularly if the names of the physicians are not part of the name permit. They don't it doesn't register. Our second issue is in terms of being able to search on the database, I'm hoping this will be taken care of in Breeze someday, of being able to see which physicians are associated with which practice. That has come up with us, particularly around the issue of med spas, of physicians being associated with multiple, and we've tried to sort of use the fictitious name permit to approximate, try to dig out who's associated with which practice. So someday that would actually be really helpful as well, and I think that will help on the pain management and the med spa issue. Thank you.
Thank you. Seeing no additional public comments from those in the audience and on the telephone, we will now continue to agenda item 19, discussion and consideration of proposed regulations to amend the continuing medical education requirements. Mr. Warden.
Okay. At the July board meeting, the licensing committee had a presentation from Ms. Clothier, who is vice president of the American Board of Medical Specialties and State Health and Public Affairs, and she made a presentation about ABMS maintenance of certification requirements. During that presentation, some of the requirements for physicians who are ABMS board certified is a lot of CME, which we have a CME requirement for physicians to meet. However, the maintenance of certification requirements for some of the boards does not meet the requirements for our CME, and so our physicians would be actually doing double CME to meet our requirements. This proposed memo I have in your packet on board packet 19-1 through 3 is an outline of what we could do to change two regulations regarding that, so that physicians who are required to do maintenance of certification meet our CME requirements by doing that without having to take extra. So one of those would be currently Business and Professionals Code 2190 requires the board to have CME to ensure continuing competence, and then California Code of Regulations section 1336D requires the physicians to complete a minimum of 50 hours of approved CME every 2 years, and they must certify that they have completed that 50 hours at the time of their licensing renewal every 2 years. Section 1337 is the area that actually says what's approved, and the proposed language that we have is on for that change, which is to add a section which would be 1337G, which is in your packet on board 19-2, which you'll see is underlined, which basically states continuing education as required for maintenance certification by American Board of Medical Specialties affiliate boards or other specialty boards approved by the Medical Board of California. So that would include any of those CMEs that you would be required for your maintenance certification to be included as being recognized. And then on page 19-3 is section 1338, and we have modified that on section D, section DA1, and we've eliminated, you'll see a strikeout for and then an underline for under section 2 to include A and G, which would allow us to obtain those records directly from the maintenance certification boards to satisfy meeting the requirements of providing proof to the board if you're audited. And so then I would like to have a motion by the board to approve.
So moved.
Okay, thank you. There's been a motion and a second to direct staff to notice the amended regulatory language and to set a hearing. Ms. Dobbs?
On section 1338D, I think it should just be G, not A and G.
Okay.
So I think we should strike A.
So noted.
Right.
Thank you. The motion incorporates that suggested edit from council. Are there any questions or comments from members of the board? Yes.
Thank you, Mr. Warden. It's time. We're a little late, but the MOC has been going on for a while, but I think I'm so glad that we're doing the MOC CME is a lot tougher than the standard CME, so we weren't counting that before. So,
Thank you. Are there any comments from the audience? Any comments from the phone?
No comments at this time.
Thank you. There's been a motion and a second. All those in favor?
Aye.
Opposed? Abstention? Motion carries. We will continue to agenda item 20, Special Faculty Permit Review Committee recommendations. Ms. Yaroslavsky?
Thank you. The Special Faculty Permit Review Committee, as described on BRD 20(1 through 5), held a teleconference meeting on August 14, 2014, and reviewed 3 applications, one from Stanford University, one from UC San Diego, and one from UC San Francisco. The Stanford University applicant is Dr. Maurice Ohayon. Dr. Ohayon is the world-renowned scholar whose work is at the forefront of the field of epidemiology encompassing sleep, neuropsychiatric conditions, and co-occurring disorders. In addition, he has an expertise in forensic psychiatry and public mental health. His skill set is in complex patient evaluation, advanced psychotherapy models, and targeted psychopharmacology will significantly expand the existing clinical programs in the Department of Psychiatry and Behavioral Sciences at Stanford University. His medical school and postgraduate training is on page BRD 20-2 of your packet. In addition, he holds a Doctorate of Science degree in Mathematics and Computer Sciences from the University of Marseille and a PhD in Human Biology from the Claude Bernay Lyon #1 University. He has 230 peer-reviewed journal articles published, and 99 as first author, 67 as sole author, and 26 as the senior author. He's published 6 books and 18 chapters. In addition, he has made 138 presentations at national and international meetings. He will hold a full-time faculty appointment as a professor in the Department of Psychiatry and Behavioral Sciences at Stanford University. He will provide clinical care, including evaluation, psychotherapy, and psychopharmacology in the adult outpatient psychiatry clinics in the Department of Psychiatry and Behavioral Sciences at Stanford. And the committee recommends that the board approve him for a special faculty permit, and I make the following motion. The board approves Dr. Maurice Ohayon for a Business and Professions Code Section 2168.1A, 1B5, special faculty permit appointment at Stanford University of Medicine. Need a second.
Is there a second?
Second.
Are there any comments from the members in the audience? Any comments on the phone?
No questions or comments at this time.
All those in favor?
Aye.
Opposed? Abstention? Motion carries.
Okay, the second doctor is Dr. Del Campo Casaneas. He's the director of the Scientific Advisory Committee of the Orpheant, Spain. He is certified by the American Board of Medical Genetics and is one of Europe's foremost clinical geneticists and dysmorphologists and outstanding clinicians, specifically in the study of treatments and interventions for children suffering from fetal alcohol syndrome and fetal alcohol syndrome disorders. Excuse me. His medical school and postgraduate training is on page BRD 20-3 of your packet. In addition, he holds a PhD in pediatrics from the Universidad de Autónoma de Madrid. Del Campo Casaneas was first certified by the American Board of Medical Genetics in 1999, and his current certification is through 2019. He has 34 peer-reviewed research articles and is the co-author of 1 book and has written chapters in 5 additional books. He's the director of the Scientific Advisory Committee at this institute that he's at. In addition, he's the leading contributor for global health initiatives on fetal alcohol spectrum disorders sponsored by the NIH and WHO. At UC San Diego, his responsibilities will be to hold a full-time faculty appointment as the Associate Professor of Clinical Pediatrics at UCSD, and if approved for the SFP appointment by the board. He will be caring for patients with dysmorphologic, genetic, and tetralogic conditions at Rady Children's Hospital, along with collaborating or leading leading clinical research projects. He will also be providing education instructions to fellows, residents, and medical students. The committee recommends the board approve Dr. Del Campo Casillas for a special faculty permit appointment, and I make the following motion. The board The board approves Dr. Miguel Del Campo Casillas for a Business and Professions Code Section 2168.1 A1B special faculty permit appointment at Stanford University School of Medicine.
Second. There's been a motion.
Wait, but he's at UC San Diego, so there's a mistake in the, I apologize.
With
It's-
that,
UC San Diego.
okay, with that notation, there's been a motion and a second. Are there any comments from the audience? Members of the public, any comments from the phone?
No comments or questions.
Thank you. All those in favor?
Aye.
Opposed? Abstention? Motion carries.
The last applicant is Dr. Moore, Dr. Anthony T. Moore. He's an international leader in pediatric ophthalmology and a renowned expert in gene therapy for inherited retinal degenerations. Dr. Moore has over 300 peer-reviewed publications, 2 books, 40 book chapters as well. Dr. Moore has previously received the following awards in 2003, the Franchetti Medical of International Society of Genetic Eye Diseases and the Claffey Memorial Medal for the at the University of Sydney. At UC San Francisco, he will hold a full-time faculty appointment as a pediatric ophthalmologist and a professor of ophthalmology if approved for the SFP appointment by this board. Dr. Moore will provide clinical care for pediatric ophthalmology in the outpatient services and inpatient pediatric ophthalmology consultant services. He will conduct research in the field of inherited retinal degenerations along with teaching medical students, residents, and fellows, both didactic and at the clinic. The committee recommends that the board approve Dr. Moore for a special faculty permit, and I make the following motion. The board approve Dr. Anthony T. Moore for Business and Professions Code Section 2168.1 A1A special faculty permit appointment at the University of California, San Francisco.
Second. There's been a,
Thank you.
thank you. There's been a motion and a second. Are there any comments from the audience on the motion? Any comments from the phone?
No questions or comments.
Seeing none, all those in favor?
Aye.
Opposed? Abstentions? Motion carries. Thank you, Ms. Yaroslawski.
My pleasure.
We will now continue with Agenda Item 21, Discussion and Consideration of Legislation and Regulations. Hello.
Hello, good morning. Okay, please turn to tab 21 in your board packets. First, I would like to report that I have contacted legislative offices in the San Diego area and invited them to attend our board meeting, and you saw someone from the Speaker's office was here earlier this morning. Just for an update on where we are in the process, the 2014 legislative session has ended, and the legislature does not reconvene until December 1st. The governor has taken action on all bills that we have taken positions on. This is the last year of a 2-year session, which means if a bill did not pass this year, it's basically dead. If you will look at under tab 21, you'll find your tracker list in the front cover. The bills in pink are board-sponsored bills, and the bills in blue are bills the board has taken a position on. All bills on the list were signed into the law by the governor. I will only be giving a brief summary of each bill and then discussing the board's implementation plan. If any members have questions on the specifics of the bill, please let me know. Of note, every implementation plan includes a newsletter article in the winter newsletter and notifying and or training board staff. So I won't say that every time, but just please know that's in our implementation plan. So if you go to the first bill in pink, that's the first board-sponsored bill, it's AB 1838 Bonilla. This bill allows graduates of accelerated and competency-based medical school programs to be eligible for licensure in California if the program is accredited by the LCME, the Committee on Accreditation of Canadian Medical Schools, or the Commission on Osteopathic College Accreditation. The board's implementation plan is to update the board's website, publications, and forums. I'll move on to the next bill if no one has questions. AB 1886 Eggman. This is the posting bill that allows the board to post the most serious disciplinary information on the board's website for as long as it remains public. The board's implementation plan is to update the board's website and publications, identify documents that were taken off the board's website due to the 10-year rule, and place these documents back on the board's website, work on processes and procedures to identify malpractice settlements over 5 years for posting, and for those over 10 years to be available to the public if requested, but not placed on the website. To send an email blast out to all physicians, alerting them of this change in posting requirements, and to update regulations through a Section 100 change, which is basically just like a faster way of doing regulations for the citation posting to 3 years, because that went from 5 to 3, and that's in our regulations, so that will need to be updated. There's no questions. I'll move on to the next bill. SB 1466 was our health omnibus bill, and the provisions that impact the board include making the American Osteopathic Association Healthcare Facilities Accreditation Program an approved accreditation agency for hospitals offering accredited postgraduate training programs, and also striking scheduled from existing law that requires physicians who perform a scheduled medical procedure outside of a hospital that results in a death to report the occurrence to the board within 15 days. The board's implementation plan is to update the board's website, relevant publications, and forms. So if there's no questions, we can move on to the bills in blue. AB 186 Mainshine allows spouses of military personnel that have moved to California based upon active duty orders of the military spouse and who have a physician and surgeon license in another state to receive a 12-month temporary license if they meet the licensing requirements, complete an application, and provide specified information to the board. The board's implementation plan is to develop procedures for staff to process these temporary licenses, which would become full unrestricted licenses once all the documentation is received, to identify a licensing staff member to be the single point of contact for all temporary licenses, to work with Department of Consumer Affairs on BREEZE processes, and post information for military spouses on the board's website regarding how to apply for a temporary license and the eligibility requirements. There's no questions. I'll move on to the next bill. AB 496 Gordon. This is a bill that amends the existing cultural competency CME requirements to also include information pertinent to the provision of appropriate treatment and care to the lesbian, gay, bisexual, transgender, and intersex communities, LGBTI. The board's implementation plan is to notify agencies that accredit CME of this new requirement, to include an agenda item at a future licensing committee meeting to hear from CME accrediting organizations on how they have addressed the amended competency requirement, and to include information on this new requirement on the board's continuing medical education webpage. So I'll move on to the next one. AB 809 Logue. This is the bill that we were, I think we mentioned it before regarding telehealth, the telehealth provisions. It revises the informed consent requirements relating to the delivery of healthcare via telehealth by permitting consent to be made verbally or in writing. And this is kind of an important one. Will make a change at the board. It deletes the requirement that the healthcare provider who obtains the consent be at the originating site where the patient is physically located. So that's kind of a big change. I know we kind of talked about the in-person thing a little bit yesterday, and we have been citing this section for some of the stuff, they have to be in person, and we can no longer cite this section because that requirement was deleted. So, it's actually an urgency statute, which means that it took effect as soon as it got signed into law by the governor. So if it's not an urgency statute, all these bills take effect January 1st, 2015. But if it's an urgency statute, as soon as the governor signs the bill, that means it takes effect. So it's in effect right now. So the board's implementation plan is to notify DCA, Division of Investigation staff, and update the board's website and related publications. And previously, just to give some background, when we did our letter to all staff, obviously our enforcement staff were included in all staff, so we're working on a process to make sure that all of our investigators and DFI are informed of the law changes as well. So that's something we'll be working on this year. So moving on to the next bill, AB 1535 Bloom allows pharmacists to furnish naloxone in accordance with standardized procedures or protocols developed and approved by the Board of Pharmacy and the Medical Board in consultation with specified entities. The board's implementation plan is to work with the Board of Pharmacy to develop standardized procedures and protocols for pharmacists to use when furnishing naloxone, and to bring the final standardized procedures and protocols to the board for approval. Moving on, AB 1841 Mullen allows medical assistants to hand to patients properly labeled and prepackaged prescription drugs that have been ordered by a licensed physician, podiatrist, physician assistant, nurse practitioner, or certified nurse midwife. The board's implementation plan is to notify DCA DFI staff and to update the board's website and publications. Moving on, the next bill, AB 2139 Eggman, requires a healthcare provider that makes the diagnosis that a patient has a terminal illness to notify the patient or, when applicable, another person authorized to make healthcare decisions for the patient of the patient's right to comprehensive information and counseling regarding legal end-of-life options pursuant to existing law. The board's implementation plan is to update the board's website and publications. Next bill, AB 2214 Fox, enacts the Dolores H. Fox Act and requires the board, when determining continuing medical education requirements, to consider including a course in geriatric care for emergency room physicians. The board's implementation plan is to include a standalone article in the newsletter geared towards emergency room physicians in geriatric care. So moving on to the next one, SB 1083 Pavley. This is a bill that authorized physician assistants on or before January 1st, 2017 to certify claims for disability insurance with the Employment Development Department. The board's implementation plan is to notify DCA DFI staff. Okay, SB 1116 Taurus requires the medical board by July 1st, 2015 to develop a mechanism for physicians to pay a voluntary contribution at the time of application for initial license or renewal to the Stephen M. Thompson Loan Repayment Program. The board's implementation plan is to update the board's website to highlight the fact that physicians can donate more than the mandatory $25 to the STLRP and provide directions on how to do so. The board will work with DECA staff on needed BREEZE enhancements, amend the licensing renewal applications to include information that physicians can donate more than the mandatory $25, and provide an opportunity for them to do so on both forms. Lastly, we will identify procedures for staff to process additional voluntary contributions to the STLRP. Okay, and last bill, SB 1243 Lieu. This is a bill that requires DCA and the Office of Administrative Hearings to submit specified reports to the legislature on an annual basis. This bill enhances unlicensed advertising enforcement requirements, requires DCA to develop and offer enforcement training, and amends the public meeting notice requirements. The board's implementation plan is only to do the routine items, run a newsletter article in the winter newsletter, and notify trained board staff. So it doesn't really directly impact us. So that concludes my presentation on 2014 legislation. Anyone have any questions?
Thank you. Are there any questions or comments from members of the board on that presentation? Oh, yes, pardon me.
On the STLRP bill, if someone donates significant amount more than $25, is there a tax implications, or is it non-taxable? I mean, it's not tax deduction. I'm just curious.
Yeah, it's something that I would have to look into. I'm not sure how the tax deduction portion works. Do you know? No.
Let me suggest that if the money were to be donated directly to the Health Professions Educational Foundation, so if we're talking about a large donation, it should be directed through that source versus the medical board licensing opportunity. And then, because that is a 501c3.
Thank you.
And if you have any money that you're thinking of, I'm happy to talk to you.
Just curious.
Just curious. Are there additional questions or comments from members of the board based on that update report? Are there any comments from members of the audience? Oh, yes. Okay, thank you.
Geneviève Claverol. We're not talking at all about proposition. I was concerned about proposition 45 and 46, which have a big implication.
That's not a part of the report.
No, okay. Just.
Thank you.
Maybe you can read some on it to educate.
I appreciate that. We'll pass that out to the members. Do you have any comments on the report?
Very good report as usual. I appreciate it.
Thank you. Seeing no additional comments from the public, we'll now move to agenda item, 21B, 2015 legislation proposals.
All right, and so you'll see a handout. It's kind of in the back where all the bills are. If you kind of keep turning back, right, I think it's after the tracker list. Underneath the blue piece of paper are the 2015 legislative proposals. So I'll move to the first one.
Can you hold one second?
Sure.
I want to make sure I have it.
Should just like go after the tracker 2 list. There's a blue piece of paper, and then it'll be right after that.
Thank you. Proceed.
Okay, so the first one, let me give you some background. In the board sunset report, the board included information regarding a decline in 805 reporting, and there's a chart kind of to show that decline in your the ledge proposal handout. To address this decline in reporting, board staff is proposing that the board sponsor legislation that would require physicians to report to the board when reportable actions occur within 30 days after they are finalized. There is precedence for this already, as physicians are required to report to the board actions taken in other states, felony and misdemeanor convictions, and arrests. And for those, we actually get double reporting. So we get from the mandated reporter, like the court or the arresting agency, we get that notification, then the physician also has to notify us. So what that kind of helps is with verification. So we get it from, if we got it from the courts and the physician didn't report, we would know the physician's not reporting. Our issue is right now is there's a decline in reporting, and we don't know if it's because hospital or peer review bodies aren't reporting, or we don't know if it's because they're getting trained better and there isn't anything to report. We just don't know. So what we're hoping is that if we have both parties reporting, the physician and the peer review bodies, then it will kind of help us to know if it's just a lack of reporting or if it's education that's helping so these actions aren't occurring. So the board would need to approve this legislative proposal in order to go forward with sponsoring legislation.
Before we take that vote, just for the members, for each proposal, we'll have the presentation, discussion, and then vote on it. Then we'll go to the next one. I just wanted to bring that clarity. So we have on 805 reporting. Are there any questions or comments from members of the board? No? Are there comments or public comment from those in the audience? Oh, yes, I do have cards. Julie, do you want? And then we'll go to Yvonne Chung with CMA.
Good morning. Julie D'Angelo Felmuth from the Center for Public Interest Law. I'll fill out a slip later. I didn't do one. I just wanted to reiterate for the board the importance of this particular legislative proposal. When I was the enforcement monitor of the medical board 10 years ago now, one of the things I was required to do by the legislation creating the enforcement monitor position was to look at all the sources of information coming into the board and which were the most reliable in enabling the board to detect high priority violations, high priority cases that are deserving of investigation and potential prosecution. And the 805 reporting by hospitals of internal physician peer review actions was at the top of the list in terms of reliability and importance to the board in detecting problem physicians. But in spite of that, the number of 805 reports received by this board from hospitals who are required to report has been plummeting over the years. And so we believe this is a very good legislative proposal to require the physician to self-report and provide a potentially duplicative but important other source of information of this very, very reliable information. So we urge you to support this particular legislative proposal. Thank you.
Thank you for your comments. I have a card from Yvonne Chung, CMA. And then Carol Moss. And I have another card after that. Hello.
Good morning, Yvonne Chung, California Medical Association. We have some concerns with this proposal. So currently, the chief of staff of a medical staff or other chief executive officer or director within the administration is supposed to report certain disciplinary actions within 15 days. The staff report notes that the 805 reports have been decreasing and that this change is needed to make sure that they are basically catching all the reports that should be filed. We are not so convinced that it's because of underreporting by the hospital. We don't believe there's enough evidence at this point. There's a lot of reasons why reporting may be down. Fewer physicians are practicing in hospitals. Contracting arrangements between physicians and hospitals may impact this as well. So we believe that adding another burden on physicians to report is actually going to create confusion because of the types of actions that have to be reported. You're basically requiring physicians to somehow become experts in all the things that must be reported. And what you'll probably happen is physicians reporting things that don't actually need to be reported, which has actually happened on the hospital side in terms of reporting adverse events. So there can be a lot of confusion. So it requires basically an additional level of education. There are substantial fines in place right now for failure on the part of the hospital to report. So in addition to that, the board may consider whether additional outreach and education is necessary before you kind of take the more drastic step of placing another statutory responsibility upon physicians for which, again, failure to comply or if they make a mistake becomes another possible actionable item against the physician. So we'd appreciate the board's review of our considerations. Thanks.
Thank you. Carol Moss.
Hello.
Hi.
Hello. I'm here on behalf of Consumers Union, the Safe Patient Project, a nationwide campaign that is organizing patient safety advocates from across California as the California State Safe Patient Network. I want to speak with you today on behalf of our recommendations related to the outpatient surgery settings proposal in your document, Legislative Proposals 2015.
I think we're going to get to that one.
Oh, are you?
We're not there yet.
all
We're
right,
doing, yeah, it's okay. No, we'll make sure to call your name when it comes up. Marianne Hollingsworth? Hi.
It's on 805, right? Yes.
Thank you.
Hello, my name is Marian Hollingsworth, and I'm here on behalf of the Consumers Union Safe Patient Project, a nationwide campaign that is organizing patient safety advocates from across California as a California Safe Patient Network. I want to speak to you today about our recommendations related to the Business and Professions Code Section 805 proposal in your document, Legislative Proposals 2015, which was made available for today's meeting. In its legislative proposals, 2015 document, the board staff identifies the concern that historically low number of 805 reports made to the board has been declining further. We support the board staff legislative proposal to require that physicians, in addition to current 805 reporters, report to the medical board when reportable actions occur. However, we doubt this change will have much impact unless the medical board takes additional action regarding Section 805 requirements. Currently, 805 reporters must report restrictions on staff privileges that are imposed for medical disciplinary reasons for a total of 30 days or more within any 12-month period. Our concern is that the hospitals may regularly avoid such reports by limiting the length of their actions to less than 30 days, allowing them to circumvent the spirit of the 805 law and allowing restrictions to go unreported. An example of this is a Fresno cardiologist who was given a 14-day suspension for leaving the operating room before a procedure was complete. The suspension was not required to be reported to the medical board. We recommend that the proposed board-sponsored legislation require that all such restrictions be required to be reported to the Medical Board of California, not only those that last for a total of 30 days or more. Thank you for your time.
Thank you for your comments. There are additional comments from the board. Dr. Kraus?
Thank you. I think it's important to look at numbers, but I think it's also important to consider the multiple ways in which we may analyze the numbers. And as stated yesterday, not every variation is a trend or an indication of a problem. And I would recommend that when statistics are presented by the board or to the board, that we ask for a statistical analysis of significance. There are some variations that are within variation of random probability and other variations that carry statistical significance. As I look at this report, from fiscal year 2004 to 2005, the 805s went down from 157 to 110. That's a huge drop. But then in 2006, there were 138. So if we look over the years of 2010, 11, and 12, yes, they're lower than the years of 2002, 3, and 4. But number one, does that meet statistical significance? And that's information that we're missing. And number two, a decline in 805s is not necessarily ipso facto an indication that hospitals are underreporting. Maybe it's an indication that the medical board has been doing such a good job of weeding out bad doctors that there are fewer 805s to report. So I'm not suggesting that that's the cause of it, but I'm suggesting that we should not rush to interpret or misinterpret numbers as an indication of a problem.
Doctor? Then we'll go to Sharon.
What I would suggest is that this is a somewhat complicated issue. I would like you to get some input from organized medical staff section of CMA. All the hospital medical staffs are represented there. So just work with them rather than fight with them. After the legislation goes through, it's a lot easier to, it's like concerned parties meeting. So I think get input, and then I have no problem you going ahead, because we do need to make sure that what needs to be reported, period. But work with the medical staff sections.
Thank you, Dr. Levine.
Yeah, I think there are two parts to this. And I agree with Dr. Kraus that the issue of how the data is interpreted is critically important. The denominator, one hypothesis is that the denominator of physicians with hospital privileges is substantially lower than it was a decade ago because of the emergence of the hospitalist movement and the fact that we have a smaller number of physicians whose work is essentially exclusively dedicated to the hospital. But before we get to the interpretation, I think what this legislation is intended to do is to just verify that the numbers are accurate. I have my own hypotheses about, why it might be fewer, and I think to me, I think the biggest issue is a change in the denominator, particularly between 2000 and 2010. And I acknowledge that before we fight about the interpretation, we ought to at least agree that the numbers themselves are accurate. And this just provides another way of validating the information. And as Ms. Felmuth said, historically hospital reporting has been quite reliable, and I think hospitals, because of the fines involved, also take this very seriously. So before I think this is just a way of answering a question about are the numbers we're getting on 805s accurate? And, I'm not sure that this, my own feeling is that as long as this bill is written carefully, it should not impose substantial burden on physicians. I think that's a legitimate concern. We need to make the reporting easy, and I think having the hospitals as part of the conversation with the physicians can transmit the information about whether or not a disciplinary or conversation actually translates into something that needs to be reported to the medical board. So working with the California Hospital Association, and I'm thrilled we have an in with that organization now, to ensure that this doesn't represent a physician scratching their head and saying, now what do I do?
Thank you. Those are some informed comments from the board. There's a motion to support, which I support as well, and a second to proceed with this seeking an author. All those in favor of the motion?
Aye.
Aye. Opposed? Abstentions?
Abstain.
Okay.
I just want to take our comments into consideration.
Well, I'm going to, thank you. There's one abstention. Dr. Kraus, thank you. The motion carries. Next item.
And I just want to let you all know that, of course, we'll work with all the interested parties as it moves through the legislative process. We can start meetings now. The language, once we work on that, we can fine-tune the details, but we will be working with all interested parties. Okay, so the next proposal was briefly mentioned in the MAC update yesterday related to midwife assistants. So it has been, and this was actually an issue that was included in our Sunset report as well. So it's been brought to the attention of the board that licensed midwives need to use assistants. However, there's currently not a definition for a midwife assistant in statute or the specific training requirements or duties that a midwife assistant may perform. So just anecdotally, we've heard that some licensed midwives use other licensed midwives as assistants, while some use a midwife student who is enrolled in a recognized midwifery school or who has an official agreement with the student in midwifery school to provide clinical training. Other licensed midwives use someone who may or may have not had formal midwifery training and or someone that that licensed midwife has trained. The duties that a midwife assistant perform also varies greatly from licensed midwife to licensed midwife. Board staff believe that this is a serious consumer protection issue and that legislation should be pursued to define midwife assistants and define the services they can provide. Board staff is proposing that language be pursued to ensure that midwife assistants meet minimum training requirements, and these would be very similar to the requirements for medical assistants pursuant to Business and Professions Code Section 2069. The statute should also set forth the duties that a midwife assistant could perform, which should be at the same level as duties that a medical assistant can perform, technical support services only. The language should also allow the board, through the Midwifery Advisory Council, to adopt regulations and standards for any additional midwife technical support services. So the board would need to approve us going forward with this legislative proposal.
Is there a motion?
So moved.
So moved. There's been a second. Are there any additional questions or comments from members of the board? Any comments from the audience? I have no speaker cards on this one. Any comments from the telephone?
We do have a question or a comment from Sarah Davis with the California Association of Midwives. Please go ahead with your comment.
Good morning, Sarah Davis, California Association of Midwives. The CAM is definitely in support of this proposal, and we think it will both serve the midwifery community and consumer protection in California. Thanks.
Thank you for that comment. Are there additional comments from the telephone?
We have no additional questions or comments.
There's been a motion and a second. All those in favor?
Aye.
Opposed? Abstentions? Motion carries. Thank you. Next item.
Moving on, in your package, you'll see we have a series of outpatient settings legislative proposals. There are 3 that have been previously approved by the board, and as you may remember, they briefly went into a bill last year, SB 966, but because of the lateness of that amendment to the bill, it was decided that we take it up this year instead, and we'll be working with Senate BMP staff. We've already met with them, and they plan on going forward with legislation this year. I don't know if the board needs to approve those proposals again, or if we can just move forward with those proposals. And the ones that were already approved is the data reporting to OSHPD. It's the inspections unannounced and every 2 years, and then peer review. So I can go over those again, or we can just move on to the one that we have not approved.
So the board has previously endorsed these positions, and if there's no, is there a sense of the board to change position? I don't think so. These make sense. You can proceed.
So I'm going to go on to the one that you have not yet approved. And we've heard this issue from CASA and other organizations related to currently CMS ambulatory surgical centers are considered a peer review body, and they're required to report specified actions to the board. However, a CMS certified ASC is not authorized to request peer review reports from the board prior to granting or renewing staff privileges. So they have asked us to add them into that section because it's not really fair for them to have to report in and then not be able to get the data. And so what we're suggesting is that change, and also a change for accredited outpatient settings to have the same reporting in and the same ability to get the reports out. And so that would be our suggestion. And we've run this by CASA and some other agencies, and they seem, there's no formal, but they seem to be fine with the language, and it's something that they'd actually, everyone would like. So we figured since we might have an outpatient settings bill anyway, this is something that we could add into that.
just ignore my ignorance. I'm just trying to understand what you said, Jennifer, really exactly. So
Okay.
can you explain a little more and see what?
Yeah, sure. So right now, certified ASCs, which are ambulatory surgical centers, are certified by the CMS. They're required to report in as a peer review reporting body. And so they report in that information, they turn that information into the board. However, when they don't have the access because they're not listed in our statute as being able to check those reports prior to granting or renewing staff privileges. So although they report that information in, they can't check that information out from the board. And so it's the same thing for accredited outpatient settings. So right now, they don't report in, and then they can't get that information out. Go ahead, Kim.
So right now, we have a database for anybody who is verified under 805.5 to obtain information. So when a physician gets an 805 report filed against them, it goes into this database. If it's termination or revocation, it's public information. But if it's anything other than that, the only information that can obtain the information that an 805 has been filed are these individuals listed. So for example, a hospital. Hospitals can get 805 information to know if another hospital has filed an 805 against a physician. And there's a certain group that's listed in the law saying who can obtain that information. For CMS approved or certified entities, they have to do peer review and they have to report into us to put it in that database, but then the law doesn't allow them to get the information out. Accredited agencies don't even have to put it in, nor can they get it out. This is a large consumer protection issue because you're credentialing somebody, but you don't know if any 805's been filed against them.
Thank you for that clarifying question. Is there a motion?
With support.
It's been moved and seconded. Are there any, we do have public comment. Ms. Moss? Yeah. Hello.
Hello again. So again, I'm Carol Moss, and I'm here on behalf of the Consumers Union Safe Patient Project. I also am a voting member on the HAI Advisory Committee for the state of California. As a nationwide campaign, this organization, Patient Safety Network, provides advocates from across the state in the Safe Patient Network. I want to speak to you today about the recommendations related to the outpatient surgery settings proposals in your document, Legislative Proposals on 2015. That was made available for us for the meeting today. We support your legislative proposal to require the physician-owned outpatient surgery settings report data to OSHPD. We encourage you to expand the legislative proposal to include all ambulatory surgery centers in order to get a full picture of the procedures being done in California. We have concerns about your proposal to pursue a legislative requirement for peer review, details of which were not included in the proposal documentation. Peer review is not working well to protect patients, safety in hospitals, and we have an even greater concern about the feasibility and value of establishing peer review in physician-owned outpatient surgery settings. We are concerned that if the medical board sponsors and passes legislation to put in place peer review in outpatient surgery settings, this may give patients and policymakers and others a false sense of safe security. How would this proposed peer review happen? Unlike hospitals, outpatient surgery settings are frequently small establishments that involve only one or two physicians, or involve multiple physicians, all of whom are financially invested in the outpatient surgery setting. Imagine the conflicts of interest where only two physicians work in a setting. Will they peer review each other, or consider the conflicts of interest in outpatient surgery settings with multiple physician owner investors? Could the physician reviewer in a practice with multiple investors be a financial partner in a practice? What peer review rules would apply if a physician is performing a variety of surgical procedures? Will several qualified California licensed physicians be required to do the review? Patients will find it very difficult to believe that independent, unbiased peer review is likely to occur absent a carefully drafted, detailed approach calling for consistent, trustworthy process to protect patient safety. We urge the board to require board certification and hospital privileges of physicians performing surgeries in these settings. We disagree with the board member assertion back in October of 2013 meeting that was proposed per peer review concept that would make unnecessary the statements that we recommended. And these were the statements. Okay.
You need another minute?
Yeah, that'd be great.
Thank you.
So we had recommended that physicians performing surgeries that require general anesthesia in outpatient centers be board certified and also have hospital privileges for the specialty procedures they are performing in outpatient surgery settings. Finally, we are concerned about the feasibility of creating a peer review process in physician-owned outpatient surgery settings. We do support the proposal before the board requiring CMS certified ambulatory surgery centers to report to the medical board actions as they take against physicians. We also urge you to impose the same reporting requirement on physician-owned outpatient surgery settings.
Thank you.
Thank you.
Thank you for those comments. Dr. Ganadev?
Yeah, just, Ms. Moss, just to give you a brief, in October board meeting, you mentioned already we extensively discussed the outpatient surgery setting task. And the task force had multiple meetings, and there also we discussed, and so this was already passed. So I just want you to go back and look at that, and that will show you, I understand that you don't agree with some of the stuff this board passed, but it's all there.
Ms. Moss, we have your comments.
Okay.
I was just going to my colleague to further elaborate on some of the work that the task force done, but we're done taking comment.
Can I ask a question?
We're past that stage now, but I will stay after the meeting and answer any questions.
Okay, that'd be great. Thanks.
Absolutely. Thank you. And I appreciate your cooperation. Was there a motion? I don't. We did. Thank you. Thank you. We had a motion and a second. Public comment. Are there any comments from the phone?
No questions at this time or comments.
Okay. All those in favor? Aye. Opposed? Abstentions? Motion carries.
Okay, moving on. We also have some technical cleanup, and we historically do this through the omnibus bill. And so we have numerous clarifying changes for allied health licensure sections, and we've had some issues taking discipline related to unlicensed practice, probation, cite and fines. So we just need some cleanup in some of those sections to allow us to have statute authority to do some of those issues. And then for physicians and surgeons, there's just a few technical clarifying changes that staff have come up with that are needed. So we would like approval for staff going forward with these technical changes and working with Senate BMP to get these into the omnibus bill.
It's been a motion.
Second.
And a second. Are there any comments from members of the audience? Any comments from the phone? Okay, thank you. Seeing none, all those in favor?
Aye.
Opposed? Abstentions? Motion carries.
Okay, and so the last proposal is one that was brought up yesterday in executive committee, and I know that we are going to discuss it this time, and it came up in the conversation of our statement adopted on marijuana for medical purposes, and it was brought up that perhaps there should be a legislative statute change pursued to require that the exam be made in person prior to a physician recommending marijuana. So I just wanted to open up the discussion on that.
Are there any additional comments from our questions from members of the board?
I have a question. I'm sorry.
Okay, Dr. Levine, and then I'll.
Yeah, so I think before, I would agree that it may be very helpful to clarify what constitutes the appropriate conditions under which a recommendation for marijuana can be made. And I just think we need to be very careful as thinking about what that is. And it's not as, to me, it's just not as simple as an in-person versus a non-in-person. The issue of whether or not there is an existing relationship in which there has been ongoing a physician-patient relationship, as opposed to saying that at the moment the physician determines that marijuana may be useful to alleviate symptoms, I think we could get into trouble if we look at this as a off-on in-person versus non-in-person. So I'd be very cautious about labeling it that. But I'd be supportive of a proposal to explore legislative intent around clarifying the situations under which a recommendation for medical marijuana would be considered congruent with good medical practice. I just don't think it's as simple as in-person versus non-in-person.
All right, thank you. Dr. Kraus?
I agree with and appreciate Dr. Levine's comments, but that might be a harder bite to take and to accomplish in the next legislative session. What I'm most concerned about is that we think of a physician-patient relationship as a circumstance where a patient has a symptom, has a problem, or wants to be a checkup, and seeks a physician's evaluation for treatment of a problem. Marijuana, and in many cases opioids, are circumstances where the patient knows what they want and the reason that they want it, and sometimes then they will seek a doctor because that's the gateway to obtain that which they wish to have. I'm concerned that under existing law, that people who desire to have marijuana for whatever reason can Skype by telehealth to get a recommendation for marijuana. So specifically in that circumstance, the motion as stated yesterday was to establish a medical board policy position and to lobby for legislation to require that a recommendation for marijuana for medical purposes require an in-person good faith examination by a California licensed physician. And I think that that's something that may be more easily accomplished than trying to legislate an existing physician-patient relationship to obtain marijuana.
Are there additional comments? Dr. Bishop?
I think Dr. Levine took most of what I wanted to say, but I also because I agree with her 100%. One of my ignorances is what the current law requires. Does the current law require? Well, I mean, there has to be a good faith exam. I believe the current law requires a good, and maybe you can help me with this. A good faith exam. It doesn't suggest the absolute nature of that exam, I don't think, or does it? Because the only thing that an in-person exam would provide you versus a telehealth exam would be a physical examination, and even much of that could be done over good high-definition camera. You can't do, but so I'm questioning the need for this change.
Dr. Lewis?
I know that in the CDCR, we utilize telemedicine, telehealth extensively for many of the subspecialties. And in that situation, a good faith exam requires another licensed health provider, such as an RN, on the other side of that camera to be assisting that physician in doing the good faith exam. So I think, as Dr. Levine said, I think if we clarify what we mean when we talk about a telehealth exam and the requirements to establish that good faith exam, I think that'll add some clarity to the board's position and to assist with legislation.
So that the clarity that I would also like to ask to be included is the issue of the prescribing physician and the maintaining of physical medical records and co-locating of the exam. It's all part of the same thing. It's the issue of the continuity of care. It's the implications of the person making the recommendation is making the recommendation and maintaining records and maintaining a treatment plan and ensuring that there's a follow-up opportunity. So it's not a simple solution. There's not a simple fix here, but that all of the parts of whatever a doctor is going to make a recommendation, be it a pharmacological antibiotic or a recommendation for medical marijuana, that the rules are the same across the board.
So member, thank you for that comment. Members, let me see if I can propose something that may work, and that is, this is, as was stated, and I think is recognized, this is a complex issue. It touches federal, state, and local municipalities and how they deal with marijuana for medical purposes. It is a controversial, but it's an issue that generates a lot of discussion, and people, smart people, are still sort of figuring it out. We do know, however, what the existing law is, and many of which, all of it, governs this relationship that we're talking about now. What I propose is, before we get into, specific motions, that we take an opportunity to take advantage of our existing committee structure, and I would ask Dr. Lewis, if he agrees, to create a working group within the Enforcement Committee to look at the issue. What are the existing facts? What are the existing law? We could have at our next meeting a discussion on that, so it's a clear what we're dealing with here, because I think everyone sort of has a different idea, which is fine, but it would be a summation of the existing law, these consultations, the doctor-physician relationship, and we could have a fully informed discussion. And if that's acceptable to the board, I would ask Dr. Lewis to take that on.
Yes, I'll gladly take that on, and I'll work with staff to establish that task force and come up with an agenda for our next enforcement meeting.
And we would welcome comments from all the members of this board. I think, Dr. Lewis, you have a sense of where some of us feel.
Yes.
Thank you. So if that's the pleasure of the board.
So I would just like to remind the chair and the members of this committee, this board, that everything was fine until we stuck in, or it was stuck into us, telehealth. That everything was going according to Hoyle, everything was working as it should be, and it was appropriate, in my opinion. But this telehealth has been the angst of this whole. Modern technology sometimes is not always as good as it's cracked up to be.
Can I make...
Oh, absolutely.
Yeah, so I'm not sure everything is fine with recommendations for marijuana for medical purposes outside of telehealth. We know that these marijuana clinics, or these clinics that are purposely set up to write recommendations, they're in person. People show up with cash. They get a pseudo history taken. Rarely is any physical exam done, and we know this from undercover operations. So the in-person piece hasn't prevented the problems. So I think I do think it's more complicated than just.
I hope you were. My issue was telehealth was not the in-person exam as much as the telehealth part of it. Was it?
Yeah, all I'm saying is telehealth hasn't created the problem. It's just created a different channel for bad behavior. There's plenty of bad behavior with in-person visits.
Thank you. Dr. Gondadev?
Thank you. Telehealth is a great advancement, but every advancement has loopholes. So we just want to make sure that these loopholes are filled in. And one of them is that somebody could be looking on Skype and prescribing marijuana for medical use. So that's like Dr. Lewis mentioned, telehealth is mostly there to give specialized opinion. When there is another licensed provider is there, whether it is a nurse, primary care doctor, I mean, there are multiple different ways, and it adds so much value. But there is always somebody is going to misuse it. I think this task force is great. I think we should look at marijuana as one, but actually we should look at the telehealth things, how our exam and what we really want, how we want to use the beneficial aspects of the telehealth and try to plug in as many loopholes as possible.
Thank you. Dr. Kraus?
One allied comment that I think the task force might look at, or might be looked at, not necessarily independently, is that telehealth and the law, which no longer requires an in-person examination, could also potentially be abused in access to opioids. And I don't know if it would be the pleasure of the chair to include that with this task force or to look at it separately.
Thank you for that. Dr. Bishop? Yes, please.
I'm just concerned because of the emotional and sensationalistic aspect of marijuana that we forget that we have an existing law, and I think we should address this in a dispassionate way, see what the law says, and this should be treated like any other specialty examination. For example, when you're referred to a specialist in pain medicine, they don't necessarily have to even see you in person, conceivably, if they do a good faith examination. So I think we need to treat this as any other medical problem in a dispassionate way, lest we get too caught up in the nuances of the sensational aspect of it.
Yeah, that's a good point. Dr. Krause?
While we may be dispassionate, we know that there is an ongoing problem with excessive opioid prescribing. And we know that 99% of marijuana recommendations are for reasons other than medical purposes. So I think that these are social issues, especially with opioids, that we have to pay extra attention to.
Okay, if there's no further comments from the board, thank you for that report. We'll proceed to the next item, agenda item 22. Oh, 21C. Thank you, Jennifer. I apologize.
If you turn to after the legislative proposals, there's one more blue sheet of paper, and it's the regulations status matrix after that. And usually I just say, if you don't have any questions, I'm done. But I did want to point out one thing. The SB 1441 regulations, which you all remember because we've spent a lot of time in those regulations. Unfortunately, we just got notice from the Office of Administrative Law that they've been disapproved. However, the board has 120 days to review the reasons for disapproval and make changes to the proposed regulations to address the concerns raised by Office of Administrative Law. And Ms. Carrie Webb is currently in the process of working on this. We are going to need an interim meeting. It will probably be by teleconference on this issue. And so board members will be contacted early next week regarding their availability. So I just wanted to point that out and open it up for any questions.
Could you just mention, in one sense, what is SB 1441 for us, those of us who
It's the uniform standards for substance abusing, substance abuse and licensees,
Dr. Lewis, this board spent a lot of time on it, and staff did as well, and Carrie did a phenomenal job, and working with stakeholders and drafting these regulations. I'm a little surprised that they were not found.
Unfortunate. I think there's
they were
some
found to be
issues.
unacceptable.
So might I suggest that you have new board members on this board since 1441 has come about, and given that there's going to be a need for an interim phone teleconference, might I recommend that Ms. Webb also submit 1441 as it currently states to board members so that they can review what is on the plate to start with, so they have a better background, as well as soon as she's got some kind of materials, that also go out to board members.
Okay, we'll get the regulations out as they were submitted. My question to our executive director is, what are the next steps now? It's been rejected.
So the next step is to look at what needs to be changed in order to come into compliance with the requirements of what OAL is saying we missed. So we have to do a couple of things. We'll have to revise the language in some areas, and then we'll also have to change our final statement of reasons and make some edits there. Then we need to have a meeting once those changes, because the board has to approve those changes before we can notice it. So we'll have an interim telephone conference meeting, have those edits approved, put it out for a 15-day comment period, and if there are negative comments, which I would highly doubt that there would not be, so we will then be having another meeting to bring it back to the board for finalization and then resubmitting it to the Office of Administrative Law.
Okay.
All in 120 days.
Yeah, is there yet another option? I mean, OEL has delegated authority to yes, no. They've said no. So now we've got to go back and deal with it. Do we believe that our submission wasn't accurate? I mean, what is our response? Do we think OEL is being unreasonable?
On a couple of them, we haven't really fully looked at it because we got it so late last week that we haven't really pulled all of it apart. But on one item, we do know that there has to be a 15-day notice because of the difference between the initial statement of reasons and the final statement of reasons just on the economic impact. And that's just a procedural issue that we'll have to go through. So, and the thing is, if we don't do it in the 120 days, we lose the entire regulation package and we have to start over from scratch, going over it again.
Okay.
And that concludes my presentation.
Thank you for that report. I appreciate it. She left the best part to the end. We'll now move to the next agenda item, 22, update of Physician Assistant Board. Dr. Bishop?
Thank you. Website update, the history of the board. Our website recently was updated to include, under the About Us tab, a history of the board page. The page also contains a link to 2 historical documents regarding the creation of the board. Rescheduling hydrocodone combination products to Schedule 2. Recent federal regulations will transfer hydrocodone combination products, from Schedule 3 to Schedule 2. This change has practice implications for PAs and supervising physicians. To ensure that our licensees are aware of this change, we are in the process of updating our website to include information about this change in law. We will place this information on the home page under Highlights, and it will also be at the Licensee tab. We are mirroring the Medical Board of California's information about this topic, so that we may provide a similar message for PAs since they are supervised by MDs. Breeze update. We continue to work with the Breeze team on Breeze production stabilization issues. Our main issues are with the enforcement and cashiering aspects of Breeze and the generation of reports in Breeze. Our licensing system continues to function appropriately. We are not experiencing any delays in issuing physician assistant licenses. Board staff are routinely attending user group meetings. These meetings are helpful to the board in that staff are able to share their issues with Breeze staff and other boards to find solutions that are impacting the system and all users. The next phase of Breeze implementation for the board are online renewals. We are working with Breeze staff to develop the language that will be included in the online renewal pages. We continue to receive a great deal of support from the staff of the Medical Board's Information Systems branch. Since many of our data processing functions are similar to the Medical Board's, they are able to assist us in resolving many of our Breeze issues. We are very much appreciative and are grateful for the professional attitude and support that they provide us. Legislation of interest to the board. An important bill impacting physician assistant practice is SB 1083, PAVLI. This bill authorizes a physician assistant to certify a patient's disability after performance of a physical examination by the physician assistant under the supervision of a physician, and would correspondingly expand the definition of practitioner to include a physician assistant. The governor signed SB 1083, and it becomes law next year. The next Physician Board Assistant meeting is scheduled for November 3rd, 2014. That completes my report.
Thank you, Dr. Bishop. Are there any questions or comments from members of the board? Okay, seeing none, is there any public comment from those in the audience on Dr. Bishop's report? Any comments from the telephone? No? Okay, thank you. We'll now move on to agenda item 23 on Health Professions Education Foundation. Ms. Yaroslavsky.
There's really no updates that other than what I gave at the last meeting about the almost $32 million that's been distributed among loan repayments and scholarship dollars for this past year. We'll be meeting in early December so that at the next board meeting you'll have a fuller report.
Thank you. Are there any questions or comments from members of the board? Seeing none, are there any comments from the audience? From the telephone?
No questions or comments.
Thank you. Thank you, Ms. Yaroslavsky and Dr. Bishop, for those reports. We'll now move to agenda item 24, items for the January board meeting in the Sacramento area. We think items for the next agenda would include a regulatory hearing on the continuing medical education requirements, a presentation by the University of California, San Francisco, regarding the study they performed on Medicare using the board's physician survey. Do members have any other additional agenda items for the January board meeting? Dr. Kraus?
With our success at this meeting, I would suggest that at each quarterly meeting, the executive committee and the board have a medical board policy compendium update.
Any suggestions? You can email.
No, but I just think that it should be addressed each quarter.
Okay. Great suggestion. Ms. Wright?
Is there any way we can get a report or someone from the Office of Health Equity to come and tell us exactly what they do? That would be great.
Yeah, we'll look into that. Also, I've been talking, actually, Ms. Felmuth said there are some other entities out there that do that kind of research as well. So the Enforcement Committee had kind of told us to go back and look at everything, and so that's what we'll be doing, is looking at those entities to see who could do a report like that.
Dr. Levine?
Yeah, I think it would be helpful for us and for our loyal members of the public to hear a presentation on sort of what new developments in telehealth, where the technology is going, what is feasible. You know, the notion that anybody's using Skype for telehealth sends shivers down my spine, because it's not a secure, by no means is it a secure network. It's not HIPAA compliant. Encrypted, thank you. But you know, to Dr. Gananadev's point, telehealth began as a consultant-to-consultant technology, but it is finding vast uses in terms of physician-patient access with very cutting edge and very secure applications that enable real-time communication between physicians and patients, as well as much more sophisticated tele-ICU work. So I think I'd be happy to help find someone who could come and sort of talk about the state of the art.
I think the
That'd be
Federation...
very beneficial. Thank you.
Excuse me. I think the Federation did a review on that too, right?
They have a policy.
They have a Federation has a policy
Yeah.
that's been...
No, but that's not what she's saying.
An in-person presentation at the meeting,
Yes.
I think, would be very beneficial.
Yeah.
Sure.
So one other thing is, we are going to be in Sacramento, and UCD has a very good telehealth program that you can actually go to and watch it. So sometimes a picture is worth 1,000 words. I don't know, Dr. Levine, if that might be something on the Thursday night, if they would be willing to let us walk through the telehealth. I know that they've done that for us before. So I don't know if something like that, or if even we could go to a facility, another facility there that does telehealth, so
I
you
was
can kind of see
thinking of
it.
somebody from the technology world.
Oh, okay, all right.
Folks who are actually
IT?
well, not IT so much as companies that are looking at future-looking potential applications for telehealth.
Okay.
But I'm not to dismiss what you said, Kim. I think it'd be helpful to see it in action.
Dr. Kraus?
I think it would be apropos if the telehealth presentation was piped into the room remotely.
Yeah, totally.
Probably could do that on a secure
Testing
line.
of the system.
I'll give you your watch, of course, or your glasses.
Are there any comments from members of the audience for future agenda items? Ma'am?
Geneviève Clavrolle. Actually, it's about telehealth. You know, many years ago, the person who actually is the most knowledgeable about telehealth is Dr. Ron Payan, who established Hospital Satellite Network. And I was the VP of that organization, and we were, back in 1980, in 1,200 hospitals, 24/7. And he has done a lot of more progressive approach on telehealth. And the other individuals very much involved are Caltech and JPL, who have done a lot of work on that. And I'd be glad to give you a name if you want to contact them.
Thank you. Are there any comments from those on the phone?
No comments at this time.
All right. We'll now go to agenda item 25. Before I take that motion, I want to thank my colleagues and members for attending this meeting. It was a very productive meeting. I also want to thank staff, Kimberly and your staff, the Department of Consumer Affairs, the Attorney General's Office, and everybody else for being here. I also want to thank the public and our stakeholders, associations for attending this meeting. And with that, I would entertain a motion to adjourn.
I move to adjourn this meeting.
Second.
Motion second. Without objection, the meeting stands adjourned.